Hi everyone, my name is Kathy. I'm presenting a small talk on resuscitative fluids when to give blood. So this is a very broad topic. Trace fluid and resuscitation has been debated for years. And the small talk will probably not do it justice, but I want to hint on some of the basics and things to think about when choosing which fluids to use when resuscitating a patient. Our objectives today, I wanted to touch on is to recognize some of the components of our fluid, to have an idea of when to use which type of fluid, and to recognize the complications of fluid resuscitation. The choice of the fluid depends on the cause of the deficit, just something to keep in mind throughout the presentation, and also in our clinical decision making in practice as well. These are just some of the basic fluid options that we have. We have crystalloids and colloids and blood products. Crystalloids are smaller, they have higher permeability, which increases the risk for tissue edema as well. It provides this transient hemodynamic stabilization compared to colloids, which include albumin, dextran, and starch, which I don't really see us use that much. And then we have our blood products, which can be an entire category in its own, which includes red blood cells, plasma, and platelets. I want to highlight the normal human electrolyte values compared to our crystalloids. Not many physicians are aware of the characteristics of the IV fluids and their effects on the plasma acid-based equilibrium. Our pH is affected by three things based on Stewart's theory, which is partial pressure of carbon dioxide, the plasma strong iron difference, and the total amount of weak acids. And going to this is also a whole other lecture in itself. The main point is that if you have crystalloids with a strong iron difference greater than the plasma bicarb concentration, that can increase the plasma pH and can cause an alkalosis. And those having a strong iron difference lower than bicarb can cause a decrease in plasma pH, which is going to cause an acidosis. And crystalloids with strong iron difference that's equal to bicarb will leave the pH unchanged. So this chart kind of better sort of shows and highlights some of the fluids that we use the most common, which is normal saline, lactic pure, and plasmolite. For example, so our bicarb level is about 24, and if you completely replace our blood volume with a fluid with a strong iron difference of 24, our pH will be exactly 7.4. So any fluids with a high strong iron difference, which is highlighted right here, it will either raise or lower your pH respectively. For example, in normal saline, the strong iron difference for that is 0. So more normal saline you give to patients, it'll make their fluids tend to be more acidotic, versus plasmolite, which will make our strong iron difference more alkalotic. Colloids and blood components, these will partially hold only because the crystalloid solution is a solvent for colloids and blood products. However, there are other factors that can complicate and can also affect the plasma pH, so we're not going to go into that. Therefore, we're choosing a fluid you should consider a balanced solution sometimes instead of just normal saline based on the patient chemistries. So let's go into some cases. Can anyone, either in the Zoom or physically present, describe the abdominal sale of this patient? Yeah, so this patient is gravid. She has like this linea nigra. So this is a 35-year-old with 2 days of severe abdominal cramping, multiple episodes of non-related vomiting, pedal intolerance. Her lactation occurred about 5 months ago. She's sexually active. She denies any vaginal bleeding or discharge. Physical exam, you can see her temperature is 99, heart rate is 110. BP is 110/75, a little bit tachypnic. On exam, she's tremulous, she's vomiting at the bedside with epigastric discomfort. She doesn't have any CV tenderness. These are her labs. She has a HCG greater than 1,000, greater than 100,000. The pH is 7.5, a bicarbonate of 30, and a fluoride of 92. What would you use? Yeah. Thanks, Dr. Singer. But why normal saline? So this patient is hypochloremic, she's alkalotic. So the best choice is normal saline because this would so if you give normal saline with strong iron difference of 0, it'll help acidize, I guess, this patient's plasma components. Plus, she's hypochloremic, and normal saline has 154 chloride, which will help. All right. Can anyone describe this exam for me? So this patient has clearly chemical obesity. This is a 40-year-old male with diabetes. Coming to the ER with one day of generalized pain in the abdomen, multiple episodes of non-delayed vomiting, also with fetal intolerance and weakness. He's usually compliant on insulin. He has increased urinary frequency as well as burning on urination. Physical exam temperature is 100.3, heart rate is 110, BP is 136/90. He's very tachypnic at 25. On his exam, he appears uncomfortable. He has epigastric abdominal tenderness and some CV tenderness on the left side. His initial labs were shown as normal saline was already started, and fingertip was greater than 600. His anion was 20. His pH is 7.15, and his beta hydroxyurea is 4. And then afterwards, he repeated his labs after 2 years. His fingertip is 450, his gap is 17. So it's sort of closing. What fluids would he use next? Yeah, so normal saline can be used initially. There's different guidelines that point to normal saline as initial corrosive fluid, but it's not, there's no data showing that normal saline is the best corrosive fluid. Given that there's a reasonable amount of GI losses, sure you can use NS first because they're only going to be hypochloremic as well. But afterwards, you want to consider switching over to more balanced fluid like LR, given that his pH is 7.15. So giving more normal saline might make him more acidic.
Okay, I think, so say you have someone like this in DKA, it's called DKA loss. One of the things I do after I stabilize their vital signs is I actually switch to half normal. And so I give them less chloride and less sodium, but they get more water and they're still getting some retention of the volume, mostly water that they need. That's what I've always done, and it seems to work for me.
Can you repeat that, Kathy, for the folks at home?
Yes. So Dr. Berghammer made a note that sometimes after a normal saline initiation of resuscitative fluids, sometimes they can switch to half normal saline, which would decrease. Would decrease the chloride, Dr. Berghammer said?
Yeah, because it's only half normal, so you don't get that hypothalamic acidosis, but you still give them enough sodium and volume to stay in. And then eventually you're going to have to add potassium, and then eventually at some point, if you keep giving insulin, you'll have to add sugar, and you can give D5 half normal with potassium at some point.
I guess the only issue with that is when you have a person who's got a little soft blood pressure, a lot of the liquid part of it won't stay in the veins because it's being taken out into the interstitium. So if there's hypotensive, I wouldn't do that right away.
No.
I would definitely wait on it.
No, I would never do that until you normalize their vital signs and they look pretty well. Then it's when you switch over. Not at the beginning. You need to keep the salt, keep it the volume.
If you look at your original idea was to replace what they lost. In patients who have diabetes out of control, what did they lose? What fluid did they lose? And where did they lose it? They had an osmotic diuresis. hyperglycemia, right?
Yes.
And if you measure the urine sodium in someone who has osmotic diuresis, what is it? It's very low. Actually, what they've lost, once you've replaced their volume and they're not hypovolemic anymore, then if the original theory was to replace what they lost, then you could almost give them back D5, because that's really what they lost. If you should do it one day, is measure the urine electrolytes of someone who comes in DKA and measure the amount of sodium in the urine. It's almost zero.
But don't give them D5.
Yeah, but you could give them half normal. And that's the reason that you could give it, once they're euvolemic, once you've given them some normal saline and got their blood pressure up, you could make the argument that the rest of the fluids is just a free water deficit from the osmotic diuresis. And old Jews, we stick together. I switch to half normal too. And then once their blood sugar gets to 250, I give them D5 normal saline. I hate lactating. I hate LR because it's a mess of things that you don't even remember what you're given. So I would like to give a solution that I actually know what's going in.
Okay, Kathy, go ahead.
Yeah, for sure.
Yes.
So basically, based on the comments we have, I mean, DK management and ongoing resuscitation is controversial. But the main point is that we should consider a balanced solution, or not just NS afterwards, after the initial resuscitation. I have a nice sort of summary chart of balanced crystalloid versus normal saline done in a couple of studies. One is the SALT PD trial, which is done in non-critically ill adults, which doesn't show any difference in hospital-free days between treatment with balanced crystalloid versus normal saline. And then also the SMART trial, which is done in critically ill adults, which shows that maybe there could be a lower rate of major adverse kidney events in 30 days. However, these studies are not that great. Plus, it's hard to control a lot of the medications and fluids given in the ICU. And there's a heterogeneity of the population as well, and what they're being treated for in terms of ongoing resuscitation. So fluid resuscitation is not only about the volume; it's also about its oncotic effect as well as its influence on acid-base balance. Okay, can someone describe to me this abdominal exam?
Cycles.
Yes, so it's a little hard to see. The patient's a little bit jaundiced. There's some medusa in the abdomen. This is a 50-year-old male with chronic alcohol abuse, presenting to ER with increased abdominal distension and yellowing of the skin, with suggested fever and chills. The temperature is only given 1, heart rate is 110, BP's 105 or 75 was soft. On exam, he appears slightly confused, jaundiced. He has some hepatomegaly. His abdomen is distended and dull percussion. His labs showing that he has an AST and ALT that's elevated and LAT2. Just to keep going, so the best fluid choice to use for this patient with advanced liver cirrhosis is albumin. As a result of this osmotic effect, most of the clinical uses of albumin is based on the capacity act as a plasma expander in patients where crystalloids are not effective or contraindicated. And that's mostly in patients with advanced liver cirrhosis or advanced kidney disease. And then this patient, let me point out his examination or her examination, right? So this patient, I heard a whisper, but there's a seatbelt sign there. This is a 45-year-old patient in a motor vehicle accident. The train driver with severe pain in the abdomen, and the EMS has become increasingly confused. For ABCs, airways intact with vital bed sounds. Patient is hypotensive, 75 or 50, requires 125. And GCS is 435, so not ready to be intubated yet. On your secondary series, you noted a seatbelt sign with no gross deep deformities, and then they're doing fast and it's grossly positive. So for this patient, the best fluid to use is actually blood to resuscitate. And some complications just to think about when we're giving people fluids is an overly rapid transfusion can cause any of these things, which is pulmonary edema, ARDS, and abdominal or even extremity chronic syndrome as well. So in summary, I think a lot of us struggle with this. For one thing, abdominal doesn't tell you a lot about the patient and maybe probably can influence your fluid choice. It's questionable. I want us to be familiar with the types of fluids that we have. Again, consider a balanced solution for ongoing resuscitations and watch out for over-resuscitating a patient. These are our incidents, and thank you to the CCN people for helping me out.